the Zoll Defibrillator, but one of the things we're going to concentrate on too is just really what to expect when we have a code in the middle of it. I think that's more impressive to what we need to do rather than you learning this machine. But we're going to learn this machine and then we'll talk about the rest of it. We have a couple of these machines, and everybody knows where they live. They live out in the hallway, right in between where we exit out of the operating room, hallway going into the PACU door. They're both there on the right. There's an adult cart and there's also a pediatrics cart. So the beautiful thing is that the pediatric cart was set up by a pharmacy, and it is color-coded on the drawers. I don't know if you've ever stopped and looked at it and took time, but you can look, each drawer is color-coded a particular weight. So that's nice. So when you bring that in, if, God forbid, we ever have to, code a kid, that's the way we do it. We also have what's called a Braslow tape, which lives inside of that cart, but we also have them inside of our anesthesia machines, okay? So one of the best things in the world whenever you hear, most of the time it's anesthesiologist to room, whatever. And that's your key, because most of the time that's when we come running. It's rare that we actually hit a code button or whatever. But if you hit the door and you see them doing chest compressions or whatever, the best thing to do is just go get the cart. Now, one of the real important things is when you go get the cart is to unplug the cart, because that can become very comical if you run off with it. Yeah, I have
back it up a little bit. So where's the code button in all the rooms? I know this sounds really basic. Does everybody know that? Like in the ORs?
Near the phones.
Yeah, right by the phones,
That's
and
right.
it says right there. Yeah, but I know it's basic, but I don't know about y'all, but sometimes when things go down in emergency, you kind of have to.
We don't think about it.
Yeah, you kind of have to set it. But yeah, the code button's over there by the phone. I'm sorry.
No, you're good. We also have two other crash carts that sit out in the area right beside 5 and 6. They do not have defibrillators on them, but they do have drugs within them. And there's a PEDS cart there also. So there's 3 different things that this machine will do. Well, more than 3, but 3 that we'll talk about today. One is defibrillation, which we're going to talk about. The other is cardioversion, which we don't do very many of those, and the other is external pacing. Thank God we actually don't do any of these. I can't remember a time we used this here. I know you probably. But anyway, I'll go ahead and go over this because they require us to do this. Everybody always used to ask, is it monophasic or biphasic? All of our defibrillators now are biphasic. I don't even know if the cath lab has a monophasic.
Does everybody know what that means? Like it's okay. So monophasic is essentially if you have. We'll get into the lead placement, but if you have anterior posterior lead, okay. If it was back in the day with monophasic, which we don't have anymore, okay. The impulse would only come from one side to the other side, okay. And now that it's biphasic, the impulse comes from both leads at the same time, okay. So consequently, you don't need as much energy, all right, to overcome the impedance. So that's the difference between biphasic and monophasic. So essentially, and actually Zoll in '99, they were the first ones to market the external biphasic leads. So and we have Zoll. So.
And there's we were talking about this morning too. There's actually a reason, why you don't just hop in the operating room, put it on 200, put pads on and shock them. There's a reason behind going through the sequence of joules per shock. And, one is just as much as you can retain cardiac tissue without damage is the best. But, you do what you got to do. All right. This is a very nice machine. I think we've had this for 4 or 5 years or whatever. It comes with 2. I know everybody can't see. I thought about putting this on the cart and letting you see. But the screen down here gives you several different indicators that are really crucial in your code. Number 1 is when you put your leads on. The leads stay in the back here in a little net right here. It is a 3-lead system, very similar to what we use here on the, off of our anesthesia monitoring. Your lead button is here and your size is here. Now that's important because if you put it on and you're not getting anything, your flat line or whatever, One of the things you might want to do, of course, is look at your leads. The other thing is to change your lead selection. I think it's defaulted to lead 2, so you can change that around, or you can change the size of it. The other thing this does, which hooks up to here, which we would do after we intubate or whatever, this is a CO2 monitor. Okay, CO2 monitor do several different things. Number one, of course, it tells us how well we're ventilating, but the other talks about cardiac output, how well we are perfusing. The second line here, the red, is very nice also, and I know you guys have gone through CPR, and I hope they do that with this, but that gives you it's kind of a depth reading. Okay, it will actually tell you whether you're going too deep, too soft, speed it up, or whatever. So that's kind of a very nice thing to do with that. You do have a recorder. It's kind of nice to always use the recorder if possible, just because you can go back and look at certain things, especially times of shocks, and when you're doing that. Defibrillation. The buttons here, the black is off, the gray goes into monitor. I guess the only time I would really use the monitor is if I am transporting them from the operating room to the recovery room. Or, you know, if CareLink comes to get them, they will bring their own monitor. If we're going into a defibrillator phase, it comes over into the red. Okay, we just talked about, you know, that this is a biphasic defibrillator. It defaults to 120 joules here. As Joe was talking about earlier, when we get them in there, when you come in, you bring this in, we want to keep chest compressions as much as we can, but we also need to stop and put the pads on. The pads, which they show you here, one will go right over the heart, right in this area right here. The other comes, let me demonstrate here. Come here, Joe. No, I'm kidding, I'm kidding. The other will come right outside of here. And you don't want to put it on his scapula. You don't want to put it on the bone there. You want to put it kind of on the medial side of that bone.
Tim, I have a question.
Yes.
If they're huge and we can't roll them over right away, what do we do?
You do what you have to do.
We put the, yeah, then you put the
You
other.
put it on their side.
Yeah.
Like we did it years ago.
And also Zoll has helped us out that there's places here for the external paddle, the paddles, but they're not here. So if you're going to defibrillate or whatever, you're going straight to the sticky leads, okay? Because there are no paddles, so don't have to worry about that.
Okay. One of the other things we were talking about this morning too, what do you do if you have a big hairy guy and you're not getting?
They say don't take rheumatoid.
Wayne,
No, but there's an easy way to do it.
And Wayne helped us out this morning. You put the pad on first, and then you do. And then I guess it also could be that hurts so much that the patient may
Might wake
up,
them
and
up.
You don't have to shock them after all, that's possible.
Pads on there.
Yes.
Okay.
There
Because
are.
you can't, you can't
There
rest
are.
your one pad.
Yes, there are 2 sets of pads on there. Okay, so when you come in here, it has an analyze button. We don't obviously have a rhythm, so you can hit analyze. Then what you'll do is, and most of the time the ologist is going to be in there, or we'll be in there and we'll, you know, assist through what needs to be done. If you need to go up on the energy, they'll tell you have a button right here where you can increase and decrease, but most of the time you'll start with the default. The charge button is right beside the analyze button here, so you would hit that and it would charge it up. You would hear it. Very, 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 very important to make sure everybody is clear and backed away from the table before you discharge that, because it will go to them and it doesn't feel good. I've never had it done, but I don't want it done. I've seen it done. So you'll hit charge, clear, all clear, shock. Okay? So then what do we do if it doesn't work? Yep. And then you can increase your joules and go from there. Anything you want to add to that, Joseph?
I just, we'll talk about it again, but there's no ACLS before BLS, right? Everybody tends to, you always like to go straight to the, let's start pushing drugs and let's start analyzing rhythms and stuff like that. But unless you're doing adequate CPR, you can't really move on to the next level. So, points for Judy in the back. So.
All right, the other thing we can do off of this is we can Cardiovert, and that would go to the defibrillator also. Now, what is the thing that would separate me from doing a or there's several things, from doing a cardioversion or just defibrillation? What do I want to do to this machine? Put it on sync. Yes, so it'll sync to the rhythm of the patient. Keeps them out of P-TAC. The other thing is, of course, you want to decrease your joules, and they would tell you what to put your joules at. Most of the time it's somewhere around 75. Now, if we're in the operating room and we can't get a rhythm back, or we get something back that's just not sustainable, they may ask us to pace them. The pads stay in the exact same places we put them for defibrillation. Okay? So what you would do is you'd come down to the green source down here where it says pacer. It should start picking up. It is defaulted at 70 beats. If you are not capturing, check your pads. But the other thing you can do too is there's a button down here on the left. It's output. It's a million. What you'll do is just turn that up till you capture. And then you can turn it up a little more, turn it down, so you'll find that little sweet spot, that little place where they're going to continue to capture. Yeah, and the rate button is on the right also.
And hopefully you never have to do that because it hurts.
Yeah,
So,
it does hurt.
has anybody ever seen that when somebody's pacing? Yeah, it hurts.
Right. Okay, pediatric, we do have pediatric pads that are on the cart for them. When we use a pediatric, I hope we never have to never have to defibrillate a child, because that is bad news. But the joules to the defibrillation are 2 to 4 per kilogram. Okay?
And those are the same, actually from the old biphasic and monophasic, same thing, 2 joules per kilo. You know, so it's, did you talk about the joules? So in the so I don't know if you're old school, like if you've been doing, like a lot of us have here, been doing ACLS for 20 years or whatever. So it used to be, remember you used to stack like 200, 300, 360? Okay. So with the new biphasic Zolls, you don't really do that anymore. So it used to be 200, so now it's 120, okay? Cardioversion, it used to be 100, and now with the Zoll, it's 75. All right, and it comes up automatically on the Zoll, pretty sure, when you start to defibrillate.
Oh, it does, yeah. It is preset. Another thing we have that lives on all the, and this is across all campuses, and this stays on the side of our anesthesia machine, back where the stethoscopes and everything else hangs back there, our circuits, but this hangs on a little wire back there, and this is kind of a really neat little guide that came out of ACLS, but it goes through everything from air emboli to anaphylaxis to VTAC to failed airway. So if there's ever a question of anything, you can grab that. Okay.
And it's color-coded, which is nice.
Yes, everything's color-coded.
We gave you an article there that when we started looking at this, it's just kind of there's some things that I thought were pretty helpful, some things maybe not so much. But a couple of things that I thought were pretty good. She's just looks like she's the educator wherever she is. And she went over a couple of things, but one thing that when I started reading it, one thing that kind of stuck out to me was it's okay to be nervous in a code. And I think we have this thing where, okay, we're the healthcare providers, we're supposed to be ice water in our veins, and that's not, it's okay. I mean, what's the first thing we tell our patients when they come in? And they say, I'm nervous, I'm having surgery today. I say, well, that's normal. So, but it's normal to be nervous when things are going down, and I guess that's part of the reason that we're here, is to kind of try to, get things organized ahead of time and know what we're doing. Okay. And then one thing in this article that I didn't think was very good, so we're going to put, as an anesthesia provider, if you look, it's on page 7, and of course, anesthesia, we're going to be managing the airway anyway, but on page 7, if you look at, CRNAs are going to be, right away, they're going to see what I'm talking about. If you look at the mask, look at the mask seal, okay, they're kind of, if you've seen anybody masking an airway, you pull up on the mandible more so than pushing down, and George is nodding because he's a respiratory therapist. So you pull up on the mandible for the seal more so than pushing down. So you can see on that, so that's the only thing I would say, did you see that? I say don't do that. Did you want to talk about the compression ring? And I'm also going to talk about, since we're more experienced crew in here, and I never thought of this before, but we all do CPR every 2 years, right? So right off the top of your head, what's the compression rate? 30 to 2, or like how many per minute approximately?
100 per minute or more.
Okay, so like I said, we're a seasoned crew in here, so ironically, and I don't know, it just stuck to me this time, ironically, but staying alive when you're doing CPR, so I started thinking, the song went through my head. Now, Barry Gibb is in your head the rest of the day, that's Tim's fault. If you think about it, it's like 1 and 2 and 3 and it kind of goes along with it. But that was another thing that everybody always forgets. You take CPR and 2 months later and you're like, what's the rate? Was it 80? Is it 100? Is it 120? So it's at least 100, so 100, 120. So if you keep staying alive in the back of your head, you keep the rate.
That's a lot better than the one Judy recommended.
Another one bites the dust at the same page.
That's not good. Even though I like that song better, that's not good. So. What else? You're supposed to use 30 more minutes?
I've used my CPR more over the main on the weekends than I've ever used it in my life.
Well, yeah, different. And also, too, just because of where we are, and everybody's supposedly healthy, hopefully we don't have to. But also, how many are patients getting any healthier? No, that's number one. And also, some of the visitors that come in here, you know what I mean? Some of they're kind of stressed, and so that's easily somebody could go down out front. So that's.
Do we have an AED?
So
There is. There's one right out front in the lobby.
Mm-hmm. But you're right. This has an analyze mode on it as well. So.
Where is it?
It's on the wall, isn't it, Tammy? Like if you're walking in, isn't it on the wall on the right?
Yeah.
Yeah. Sure it is. That's exactly where it is.
I really didn't know. I don't know.
I think that's
we
where it
had
is.
an
And this is something too, is that
I've
as
seen
everybody, not to be morbid, but have you found yourself, like if you're out, I did it, like when I'm at church or something, I'm looking back, I'm like, oh man, where the AEDs are, because, I know it's morbid, but sometimes I look around, I'm like, man, that guy does not, he's not like very, I know I'm supposed to be concentrated, but that does not look very good.
Somebody was telling me yesterday about a little girl that they said if they'd had an AED at wherever she was, she could have been saved.
Yeah.
And now her parents are doing who was telling me that? Her parents are doing a campaigning to get AEDs in all wherever she was.
Well, look at Dr. Daldor's son. I mean, that's what saved his life, Christopher, several years ago. Dr. Cruz's son was one of the ones who saw him collapse.
Really?
And said, he is not doing well. They got the nurse in there, got an AED, got a shot.
Wow.
And he has a permanent pacer, defibrillator implant. And he was only, 13 or 14?
Wow.
He was high school, actually. He was high school, right?
It was right around that age.
Tim, is that one audible when it's plugged up and you got it using it? Does it talk to you like the AED does?
It's never talked to me before because we've never used it, but yes, it is supposed to.
It'll sort of walk you through it?
Yeah. Well, no. Oh, you're talking about the AED or you're
I
talking
know
about
the AED
this?
will.
Yeah. No, this is audible for certain things. Like it'll say shock, It's okay.
But it doesn't say attach pads
Right.
No, I don't think so.
like an AED will.
Yeah.
Rick, you wanna try that? You got it.
Not today.
I told you to show me your chest today. All right.
Any questions about the defibrillator?
Smart.
Okay, let's kind of.
We don't have that much more, so we'll kind of move on. But does everyone? Do you want to do like a quick sort of rhythm review?
Yeah.
Does that go with everybody? Okay. And I know in the OR nurses aren't. I mean, anesthesia's supposed to be doing the strips, but PACU always kind of helps. Do you have your little rhythm strip?
It's on the back of the
No, that's
operator's
very
guide,
well.
last page. Not the back of it, but the last page.
All right. This is everybody can chime in here. So number one, what does it look like?
Normal sinus rhythm.
Okay, what? And also, I can't. And this is when I first took ACLS. The instructor was just preaching this like nonstop. Okay, treat the patient, not the monitor. Okay, I can't tell you how many times that I've come in and somebody's like, well, they're looking at the monitor. I used to be on the code team. They're looking at the monitor. It looks great, but if your patient's blue, that's not. Your patient's not doing well. So Okay, so sinus, but the first thing, what's a patient look like? Now, if the patient with that kind of rhythm and no pulse, yeah, right, it's BEA, right, but CPR.
Do you shock PEA?
To, you know, PA, CPR, and then you try to figure out underlying cause, right, so. All right, next one? Yeah, exactly, it's a huge first degree block, a sinus Brady. So, what do? Look at the patient. I would say they're probably gonna be symptomatic with that, not always, but probably. So their interventions would be, if they're sort of talking to you, I don't feel very good, maybe atropine, oxygen, atropine, okay. No pulse with that? CPR. Okay. So, all right, this third one, that doesn't look very good. Yeah, so, all right, so, yeah, right, so that's do we shock asystole?
No.
Right, okay. Okay,
Do we
so-
pace asystole?
Maybe try.
You can try. That's right.
You can try, they're dead, you can try, yeah, they're dead.
You can hope.
Okay, so yeah, of course CPR, and then, move on from there. Okay, and number 4 on the way down there? Yeah, it looks like flutter, okay. And your rate's about, so, patient says I feel fine, everything's good. Expert consultation, right up there. So, right, that's the punt. Everything, they're doing okay, but we need to do something about it. Expert consultation. Okay, number 5. Right, so anytime you have a QRS complex, irregular QRS with no PAs, think atrial fib. Same thing, this patient is probably, we don't know, but probably chronic, they're probably feeling fine. So, sir, have you had this for a while? Yeah, okay. How about if they show up for surgery, if you're the pre-op nurse and they come in and they're like, I don't feel that good, and you hook them up, have you ever had this before? No, first time they've been in atrial fib. So we taking that patient to surgery that day? No, you're gonna take it, yeah. Get some party gifts because he's coming back. So that would be expert consultation, right? Okay,
Do
the
you
one after,
shock atrial fib?
what if it's uncontrolled atrial fib, meaning ventricular response is way over 100. They're not looking good at all. Okay, they look like they're getting ready to check out. That's a cardioversion moment. Okay. All right, the one after that. So VTAC with no pulse, you treat it the same as AFib. Okay. And one thing too, I was always taught with the VTAC. So your ventricular response with VTAC is usually 150, or usually right at 150. So if you're, and not that we routinely have patients in PACU here that go into VTAC, but if I'm in PACU, where should my alarm monitors be on the high range? If I'm just want to be on the safe side, less than 150, right? So if somebody goes into VTAC, it's going to set off my alarm. Okay. All right. So what if you look at this rhythm and they're like, I feel pretty good. I've seen that a few times, not a lot, but I've seen it a few times. I feel pretty good. And they're VTAC 150. And what do you do for that? Yeah, maybe some lidocaine, maybe some expert consultation. All right. Okay. Yeah, Cardioversion. Yeah, if they're starting to, if they get symptomatic, they can start to Cardioversion. Okay. And the next one, that's ugly. Yeah. Okay. He said. Yeah. It could be even torsade at the end there. Okay. So what if you see that? And your anesthesia provider's been shaking the patient just for fun, and they're not that we would do that. You got a PACU, or you see that? Yeah, I'm feeling fine, but you see it on the monitor, artifact. Okay. But also most of the time you're going to see that, and you're going to run the protocol for VFib, right? So CPR, defibrillation. All right. And the last one. Is there P waves in there? Trying to see. Yeah, close. Yeah. So that's SVT, which is not really about 150. Yeah, so it could be sinus tach, SVT. It all depends on, just like everything else, it all depends on the patient is symptomatic or not. Okay, symptomatic, we gotta treat it right away, probably some electrical intervention. If they're not doing too badly, consultation. Would that help at all? Everybody seems to get the rhythms pretty quickly, but I think, like I said before, circular learning, you come around, you kind of hit the same thing about once every year, it's worth, helps me, so. Yeah.
One last thing, we'll just very quickly go over, when something adverse happens in the operating room or whatever, the best thing for the circulating nurse to do, and of course whoever's going to back up and protect what they have, is pretty much to control chaos. Okay, you're going to need a runner, so it's nice to have whoever's floating or whatever there to get what you need to do, and to do some either charting on your leg or wherever where we can go back and do it under Epic. But Epic's so good now that we can catch certain things, and we actually have macros for codes that are in our anesthesia profile. But the best thing for the circulating nurse is to make sure people are aware outside of the OR, and then to control the flow of what happens, because we all have a tendency, as Joe talked about in the beginning, where anxiety hits and we all turn into Superwoman, Superman, and go towards whatever the problem is. So the best thing to do is control chaos to who comes in the room, because most of the time the anesthesiologist is going to be right up where we are, and then whatever can control on the outside will work. The nice thing about our Pyxis machines now most times we're in there, they're always open, but the drugs are always in the second and the third drawer. Now that is aligned on every campus in the Cone system. So wherever you are, if you're at Wesley or wherever, that's where they are. We also are using now pre-filled syringes. So your drugs are already pulled up, they're already right there. So if we have the airway and the ologist is doing something or whatever, and we tell you, go ahead, whoever's circulating or whatever, and get what epinephrine out or whatever we need, the drugs are right there. They're second and third drawer. And as we talked about earlier too, the pediatric cart is color-coded for us per kilogram, and we also have the bracelet strip. Yes, Jenny?
Tim, do you know if everybody has access to your Pyxis? Can anybody get in it? Because there is some controlled access built in.
They should.
Yeah, you should, yeah.
But I would say also too, if this is something's going on in the operating room, that'll be, if we're doing a case, that'll be open, so that should not be an issue to get in the middle of the case. Another thing I was gonna say is hopefully I never have to use it, but on the anesthesia monitors now in Epic, you can click like emergency guidelines, which is really not, and like I said, hopefully we never have to use that. But you can open that window and it'll take you down different algorithms, what's going on in the operating room when something goes down. So,
And that's on the computer?
Mhm.
Really?
yeah.
That's now our little sidebar. Jenny, that's a really good question, and yes, I'm pretty sure every one of you guys, yes, you can access into our Pyxis. If you guys, especially you recovery room person, who are here till sometimes 9 o'clock at night, and if something happens like it did a few weeks ago, if you have time and don't want to bring the crash cart in there or whatever, you can access our thing, and like I just said, everything is in the second and the third drawer. Everything that you could possibly want or need for that.
Can the anesthesiologist get into those drawers too, if needed?
They can, yes, they can.
Well, okay, I just,
Do they know how?
Yeah.
That's the big question,
That's a
I
different
think.
ballgame.
I
I would
think
go get it if I was you, let him stay, or her stay by them.
okay, cause some of them have,
Right,
difficulty
yes.
getting
I
into
understand what you're saying.
some of the locked
Another
boxes.
thing I was thinking about, because we talked about it a few times already, there's no
And they need
ACLS
to be
without,
able to.
no ACLS without BLS,
Yes.
is that, so everybody talks about high quality CPR, right? So if we do have something going down in one of the rooms, and let's say we're in a code, we have to think worst case scenario. So let's say we're in a code for 10 or 15 minutes, that means we're gonna need people to do CPR, okay? So if you have a bunch of rooms So if every room is running, somebody has a code, so that means Joe, Craig, Keith, you might have to stop running seeds over for a little while. And if anybody knows, yeah, no, but if anybody knows, you do CPR for 3 or 4 minutes.
That's
You-
won't work.
I mean,
That's-
yeah, you're tired. So once you get tired, you no longer have effective CPR.
They're on camera around.
Yeah, we do kind of need fresh bodies to kind of change off and do CPR. So that's
What we do is come out of scrubs and
yeah.
the scrub normally does
For that
that
too.
while everybody.
But the point is, there's still,
We still need to transition.
you still need extra people.
And that's where I was talking about, it'd be nice for the circulating nurse to kind of take over responsibility as far as running things in and out of the room. Yes, Judy?
I got a question, and this is primarily for packing people. Is there still an airway box? I know once before when we had an issue with kids or an adult having airway issues that, could potentially turn into a code. Is there an airway box?
It is.
Where
It
does
Yes.
sits
live?
back in the Pyxis area in the recovery room.
On the
By
shelf.
where the blanket is, it's on a shelf there, and Maggie just a couple months ago updated everything in there because there were some pretty old blades and
Yeah,
handles.
because we had to use it this night.
So yes. Do you understand where it is?
Yeah.
Yeah.
Beside the pillows.
Yeah.
Okay.
Where they're stacked.
Just be aware, either Donna or myself or Amy are usually here later, but, sometimes that's not always the case. So be aware that, once you drop that patient off and pack you and go back to clean up, and it's everybody's, drive to get out of here and hurry, just be aware that, especially if it's late, just try to stop by, pack you, and just check in. You usually have a clue whether or not they may or may not have an issue with a patient, just from what's gone throughout the procedure. But, just be cognizant. I try to keep the door open if I can and listen in case they need you, but just be aware that they may need you, and there is skeleton staff here late in the evening, there's nobody else here. And, the ologists, most of them are getting more seasoned coming over here than newer, but, they may not even know the code to get into the anesthesia workroom, and they do not
They
know
don't.
where everything is in
Yeah.
that anesthesia
Or
workroom.
And of course, we don't add on the sick patients at the end of the day.
No.
Yeah, so that
no,
never
no.
happens. So that never happens.
But just be aware that you may, just be a resource person to just get stuff for them and just to be there for them, be their runner, because they may have patients in, all 3 stages and, several stages in PACU, and their staff is dispersed and not have that many resources in there for that patient that they're having issues with.
Thank you, Patty. Patty helped us out that night. I just happen to remember it was about 5:30. I said, somebody page Patty this. So it is helpful. There are
Yeah.
skeletal staff sometimes in the evenings for us. And if something happens, we probably need an extra hand.
And it is really nice to be this close to the main, because that's even though we're sort of freestanding
Yeah.
ambulatory center, it's nice to have all the resources of of the big house, something like
Yeah.
that, if we have to.
Do they still have the law or rule that the anesthesiologist stays until the last patient's out the door?
No.
So
They come a lot when the patient's still in phase 1. I had one leave yesterday when the patient was in phase 1, going over to the main.
I thought that was a rule.
Well,
Supposed to be.
we might need to revisit that. It probably would be a good idea, but I think some of their peers are wanting them to come on over, kind of thing, so. I don't know how all that works, but. Yeah.
Questions?
Rule for all ambulatory centers, is it not?
I don't know.
I don't know if it's a standard of care. or-
Standards are ambiguous.
They are. I
For a
think one thing
reason.
is, I would encourage you to be proactive. I mean, if you do not want them to leave, I certainly would tell them, I'm not comfortable in this situation. Do you mind hanging out for a little while? And I think 99% of them would be very
Oh, yeah.
accommodating of that.
Don't forget the family too, if something happens, because they can hear when you page the ologist to your room, and they know what room their loved one is in, so somebody needs to come out and let them know what's going on.
There's a little snippet in there, and there's about a paragraph about, just like you said, about cultural differences and cultural sensitivities, and, you know, some cultures, I mean, it's just something that don't really talk about. It's like, you know, some people like put the window open so the spirit can leave, and, you know, things like that. And so,
So the pages are going out into the lobby now?
I thought that,
Didn't they always?
no.
They used to, but I think the last time we had an issue with that, my understanding is they tried to stop it going in the lobby, and it just,
I didn't know that.
I don't know.
Only
Do you
if
know,
you press the
Wayne?
emergency page will it go up to
Emergency
the
page will
lobby.
go out everywhere, but we did take the room numbers off the grease board, so they do not know what the room number
Oh,
of their
good.
patient is unless somebody tells them.
Yeah, that's what I was.
Yeah, so we
something.
took the numbers off the grease board out there.
Yeah, I thought so.
And the emergency page on the phones will page every room and the lobby.
Yeah.
It sure will.
So what's it have a color?
Hmm?
The board out and,
Sure, it has a color, but don't have the room number.
right.
It used to have the room number, so you knew what number your patient was in the,
But it doesn't have their name on it?
No,
It has their initials.
A number, okay.
their room
But
number,
not-
has their identification number.
Well, thank you guys.
Thank
Thank
you.